Alrighty, good evening everyone. My name is Victoria, and today I'm going to be presenting a case on a patient called HM. HM is awesome because he is based on a real case, happened back in the early 1900s. I decided to take his case that occurred back in the 1900s and apply it to modern day medicine. I did this on purpose because I wanted to talk about advancements in the field of neurology and patient care as a whole. So we're going to pretend he's coming into the ED today with us. He has a chief complaint brought in by ambulance after a witnessed seizure-like activity for 20 minutes before arriving to us. He's now on the stretcher. He's awake, but he's slow to respond. He's a little bit out of it, complains of a headache, confusion, nausea. He has a history of seizures. He's currently on Keppra daily for seizures. Vital signs look pretty good. Blood pressure is on the lower side. You notice he's a little bit tachycardic. He's got a heart rate of like 136, which can be either A, the body's trying to compensate for that low blood pressure due to the decrease in circulating volume, or potentially there are some cases which evidence has shown that after a seizure, they can be tachycardic for a little while as the body kind of resets. Get a little bit more information about him. He was born in 1926, but for the sake of this presentation and making it modern day, he is 27. He was born in 1996. He's a white male. He's from Manchester, Connecticut. No really significant medical history other than at the age of 7, he was in a pretty bad collision with a bicyclist that caused him to have some pretty heavy impact to his head. He had traumatic brain injury kind of going on there. No reported loss of consciousness back in the early 1900s. There's no documentation anywhere of MRIs, CAT scans, nothing done that I could find in terms of evidence. But kind of a timeline for him. He began having seizures every now and again at the age of 10, nothing too serious, nothing that his parents necessarily were too alarmed with. Fast forward to the age of 16, he had his first major seizure. They were occurring a little bit more frequently, prompted his family to take him to the doctors. He was put on a low dose of Keppra for maintenance. The seizures went away. So we haven't done any more following up. We kept him at that baseline Keppra. Fast forward to today, his seizures have gotten out of control. The Keppra is not doing anything for him anymore. He's so incapacitated he can't even hold a job. A lot of daily living activities are impacted by it pretty deeply. We always got to check when someone comes into the emergency department. Now that we've got him stable, we know that, he's breathing, he's not choking on anything, he's able to maintain his airway. We're going to get some blood work done, and we're going to get some imaging done to rule out any trauma from the seizure-like activity that he encountered for 20 minutes. It's quite some time to be in seizure-like activity. Sometimes they can be pretty violent, You can spontaneous and could be hitting objects around you, hurting yourself in the process because you have really no control of your muscles or movements. Lab showed prolactin was elevated, which this is a pretty normal level to be elevated, especially after a seizure. A lot of evidence points in that direction that it's a pretty significant telltale sign in blood work. Sometimes glucose can be low as well. That can also be what caused the seizure, but his glucose looks pretty good. His urine tox screen we sent off as well. It's negative. He's not on any drugs. Sometimes substance abuse or withdrawal from substances can lead to seizures. CT of the head came back with some interesting remarks. Slight atrophy, which is some shrinking of the hippocampus bilaterally. They want us to go and send him for an MRI for further evaluation. And you're probably wondering why we just did a CT. Well, the MRI is a much more detailed picture of the brain. So we want to see what kind of scar tissue is going on here, any potential tumor, malformed blood vessels, things that you wouldn't necessarily see on the CT because it's not as detailed. Sure enough, we got his MRI results back, and He does have, some pretty significant potential scar tissue occurring around the hippocampus bilaterally, which research shows can be evidence points to mesial temporal lobe epilepsy. MTLE is often associated with abnormal findings, especially scarring in the temporal lobe. It can cause hippocampal sclerosis, which sclerosis is the hardening or the scarring. And it could be on one side, both sides, but something has to look shrunk or smaller over the course. And if you know that's in figure 1, an MRI on the left-hand side there of the MTLE scarring reflected by the gray-white unsymmetrical portions that I have circled there. It's in like bilaterally where like your hippocampal region resides. You have quite a few structures that are kind of neighbors in that area, which we'll get into more as well. So first critical thinking stop sign, what do you think is most likely his diagnosis? So based on what he came in with, his blood level, the elevated prolactin, the tachycardia, the MRI CT results, the reported history of being on Keppra, not really compliant with seeing any neurologist, the progression of worsening seizures more frequently. I'll give you a moment and I'll cue the Jeopardy music up for you. If you said any type of epilepsy, you'd be right on the money. In his case, we're going to go with temporal lobe epilepsy. And you're probably wondering, what is temporal lobe epilepsy? It's actually, as reported by the Epilepsy Foundation, one of the most common forms of focal epilepsy. There's 2 types of it. There's MTLE, which we kind of already talked about. It involves the medial or internal structures of the temporal lobe, which if you look over at the figure 2 on the right, you'll see that medially the hippocampus, the amygdala, the thalamus, the hypothalamus are all pretty close together there. This is going to come up again later on, so make sure you're paying attention. Seizures often begin in a structure of the brain known as the hippocampus. Ding, ding, ding. We saw the shrinking bilaterally in the hippocampus. The neocortical or lateral temporal lobe epilepsy involves more of the outer parts of the temporal lobe, which is more towards the frontal lobe, kind of away from those structures. Risk factors for this: brain injury. Again, another big red circle, brain injury. We don't know if he lost consciousness. We don't know if he has any history of cancer or any other underlying conditions because he reported nothing else in terms of medical history. So our plan, what we're going to do for him, we're going to up the Keppra. We're going to, he's on the lowest dose. We can up him and see what happens from there. We're going to give him a lot of education. We want him and his family to know what to do during a seizure. He had some abrasion and some bruising. We want them to know safe positioning to prevent injury. Turn him on the side, clear the surrounding space so he doesn't hit anything else. Once that seizure starts, don't try and stop it. Don't put anything in his mouth. We're going to up his Keppra. So we want him to know about the dosing and the adherence, staying on the Keppra, potential side effects for it. We want him to follow up with neurology. Follow up. He needs to see a neurologist. Collaborative care. If he develops, potential, anxiety or underlying conditions from his seizure activity, especially, any issues with like his glucose levels. We want him to follow up with his primary care provider. We want him to continue monitoring his seizure activity and his Keppra dosing, especially with a neurologist. And we want him to really have some emotional support in there as well. We want him to feel empowered. We want him to ask questions. We want to ask him questions. We want to ensure that all needs of HM are met, whether that's socially, psychologically, physically, psychosocially. We want to provide him resources. Maybe he needs help affording Keppra. Maybe he needs help affording a neurologist or needs a referral. Maybe he needs, resources for support groups. We want to do the model of patient-centered care because there's a lot of evidence that points to patients who have chronic ailments and are struggling with them. They tend to have more positive outcomes if the patient-centered care model is utilized. They report positive satisfaction with care and their physical and social overall well-beings in comparison to people who do not. 6 months later, looking down the line here, he has, I understand he's no longer in our care because he left the ED, but we're still going to keep an eye on HM's story here. He got the Keppra increased. He, overall has been compliant. He even got a neurologist. His family felt good about it. However, these symptoms are still there. He's still having breakthrough seizures despite the up of the Keppra, and it's still affecting him, his activities of daily living. So with that being said, this is kind of where old medicine and new medicine kind of clash. Back in the 50s, he did have an experimental elective surgery of the bilateral medial temporal lobe resection, and it involved his hippocampus, his amygdala, and the adjacent hippocampal gyrus, which today epilepsy surgery is much less invasive than it was 50 plus years ago. Little hair was removed. We know about aseptic techniques. The surgery is much more accurate due to advancements in neurosurgical technology and instruments. Overall, during his post-op procedure, follow-up, unfortunately, he had some pretty significant outcomes from this. He really had some memory impairment after that procedure, forgetting things that were occurring after that day. So daily events, names of people he met. These are things that we define as anterior grade amnesia. It's the inability after a traumatic experience to the brain or certain regions of the brain, which in this case was his experimental surgery, not being able to remember events following that. So unfortunately, HM came out of this with a lot of association of potentially hippocampus with memory, but a lot of regions were impacted during the surgery. His hypothalamus, his amygdala, and his hippocampal gyrus, which, if we recall, they're all pretty close together in that medial section of the temporal lobe. They control the autonomic nervous system. They control the endocrine system, things like body temperature, fluid balance, flight or fight response, memory coding, and retrieval. With this being said, I'm going to hit you with one more critical thinking stop. Based on HM's subjective report, post-procedure, and becoming familiar with the regions potentially impacted during his procedure, what do you think could have potentially caused this impairment? What imaging or plan do we want to do going forward for HM to try and figure out what's causing this anterior grade amnesia? Here are my references. Thank you guys so much. I appreciate it.